Let's say you're under 40 and you get one of these scans and your score isn't 0. I don't care if it's single digits. That is a major red flag because that means you've already started this process of plaque formation. Eat real food. That's going to make you smarter, and it's going to make you not have to work as hard to be successful in life and remain healthy. They got some people, healthy people in the lab, and they showed them whatever pictures or whatever to make them angry. And they measured their endothelial markers and showed endothelial dysfunction with anger. So you got to stay happy. You got to enjoy
Sorry, New
life.
Yorkers. Yeah. Welcome back to the Smarter Not Harder podcast, your home for 1 cent solutions to $64,000 questions. I'm your host again today. My name is Dr. Scott Scher, and it's a pleasure to be back with all of you. I had a fantastic time interviewing Dr. Philip Ovadia on the podcast today. I'll give you a little bit of a history on Dr. Ovadia. So he grew up in New York and graduated from an accelerated program in pre-med at Pennsylvania State University and Jefferson Medical College. This was followed by a residency in general surgery at the University of Medicine and Dentistry at New Jersey and a fellowship in cardiothoracic surgery at Tufts New England Medical School. He has been a cardiothoracic surgeon since that time, and then he started Ovadia Cardiothoracic Surgery in 2020, working as an independent contractor throughout the United States in 2021. We talked a lot about his work at Ovadia Heart Health, offering a virtual clinic to people all over the world with a focus on prevention and treatment of heart disease by modifying diet and lifestyle. He lives in Florida, in St. Petersburg, and he came to me from Illinois, where he was doing heart surgery the day that we were having the conversation. So he's one of the few people out there that's still dividing that line, like me, between conventional medicine and the world of preventative care in various ways. And so we had a great conversation, he and I, about cardiology in various ways. We spoke initially about his work as a cardiothoracic surgeon and how the demographics of those that he's been treating has shifted dramatically over the last 20 years or so. We spoke about the world of statins and how cardiologists thought that nobody would need cardiothoracic surgeons back in the 1990s when this came around, but of course that hasn't been the case. We then spoke about seed oils, insulin resistance, and in detail we spoke about the carnivore diet and how this transformed Philip's personal health and how he actually uses this as an intervention in his own clinical practice, even with patients with advanced cardiac disease. From there, we spoke about cardiac screening. We talked about other dietary interventions and more. I really hope you enjoy this podcast with Dr. Philip Ovadia. We had a great conversation. Please like and subscribe. If you like this podcast, please share it with your friends and family. Enjoy. Philip, how are you?
I am doing great. It's really excited to be here with you.
It's nice to have a practicing cardiologist on the podcast today. And there's very few people, myself included here, that can integrate themselves in both of these worlds. Stay as a practicing cardiac surgeon as you are, and also having a practice doing integrative cardiology. And as you always say in your book, like keeping people off of your operating table. So it's an interesting juxtaposition for you. And I wanted to start off with a little bit of that. First, your primary initial job, which is a cardiac surgeon. You've had an evolution in this world, right? You've been involved for a long time. So I was hoping we could start off with talking about your work as a cardiac surgeon and how it has changed over the last several decades since you've been in practice, the types of patients that you're seeing, the types of surgeries that you're doing, and we can go from there.
Yeah, sure thing. I've now been a practicing cardiac surgeon for over 20 years, went to college even knowing I wanted to be a surgeon, and I did the 5-year residency, and cardiac surgery immediately grabbed my interest. I actually went into training thinking I was going to do trauma surgery. I found out that really didn't end up interesting me all that much, and you don't operate as much as a trauma surgeon. And so cardiac surgery, just the combination of the technical details, the physiology, it really grabbed my attention. And after completing my general surgery, I did my cardiac surgical training and went into practice. And the thing that strikes me most today, looking back at what training was like and what the early part of my career was like, is the change in the demographics of the patients, and specifically how much younger the patients have gotten. This is a pretty scary trend when I think about it, because when I went through my training and started my career, we operated mostly on 60 and 70-year-olds. We'd have some 50-year-olds, and it was pretty darn rare to see a 40-year-old ending up on the table. And today I'm routinely operating on 40-year-olds, and I occasionally see 30-year-olds ending up on my table with atherosclerotic heart disease specifically. It shows you how this disease process has changed and accelerated. I've become more aware of this as I've gotten into the efforts to keep people off my operating table. But that has been a very noticeable change, just a short span that I've been in practice. Over a 20-year career, you really shouldn't notice such dramatic changes in the types of patients that you're seeing. And yet, here it is.
Yeah. And so the type of surgery that you're typically doing on these patients, has it changed over that time? I mean, certainly what cardiac surgeons are known for is bypass operations, right?
Yeah.
Is that your primary sort of bread and butter at this point still, or has that shifted overall in the sense of who you're doing those procedures on and the younger demographics, et cetera?
Yeah, no. So bypass surgery, coronary artery bypass, CABG as we call it, remains the most common surgery I do and that most cardiac surgeons do. And again, this is interesting because when I was going through my training and I decided I wanted to go into cardiac surgery, I got a lot of pushback. People said, "What are you going into that for? We have stents, we have all these lipid lowering medications
Right.
that were relatively new then." And the perception was there's going to be nothing for you to do as a cardiac surgeon in 20 years. We've solved heart disease.
Right.
And yet the reality 20 years later is we're busier than ever. And not only is heart disease not going away, it is getting worse. It remains far and away the number one killer here in the US and worldwide. And the number of deaths due to heart disease here in the US has actually been increasing over the past 10 years. There was a time in the 1990s, early 2000s, that curve was headed downward, and we
Right.
kind of thought we had this figured out. But since 2010, it's been a upward trajectory in terms of the incidence of heart disease and the number of heart disease deaths. So
Hmm.
that led me to start to think about what's going on here. Why haven't we figured out heart disease? Here in the US, we declared war on heart disease in 1955.
Right.
So we're
Eisenhower.
now
Yeah.
70 years into this, and we've been through all the iterations of the dietary guidelines and the medications, and we're not making progress. And
Right.
that has to lead someone, when you look at a problem like that, you have to step back and say, well, maybe we don't quite understand what the cause of heart disease. Maybe we are focused on some of the wrong things. And those are the types of questions that I find myself thinking more and more about over the recent years.
Hmm. Yeah. So you came about like through your residency and training when statins first came on the scene then, right? And so it was probably very exciting for a lot of people that were like, well, we're not going to have any heart disease or we just have statins, right?
Yeah, very much so. I entered medical school 1994. Statins got introduced to the market 1987. I
Mm.
think, or 88 was when the first statin came on the market. Honestly, even by the time I got into medical school, it was sort of dogma, well accepted fact that cholesterol was the primary driver of heart disease. And in order to prevent heart disease, we have to manage patients' cholesterol levels, combination of dietary, lifestyle, and medications, although heavily weighted towards the medications at that
Of
point.
course.
Because
Yes.
by 1994, statins were, I believe, already the most widely prescribed class of medications. And of course, that has continued essentially unabated for the past 30 years. And
Mhm.
again, here we are, more people than ever are on statins. We know on a population level, our LDL cholesterol and total cholesterol levels are lower than ever. And
Yes.
yet, heart disease remains the number one killer.
Yeah. So you said that there was a trend shift in 2010, I believe. Do you have a sense as to why that was the case? Is there
Uh,
anything that you know from a clinical perspective?
yeah, so there are a couple of things that I think play into this. Number one is that it probably, in retrospect, looking at things, the majority of the decreases that occurred from about 1985 to 2010 was related to decreases in smoking rates. And
Ah,
that has kind of leveled off since 2010. Our
got it.
smoking rates aren't going back up, but they haven't decreased any further.
I see.
And then I think what was coming behind the scenes was this onslaught of metabolic disease, obesity, insulin resistance, type 2 diabetes. The trajectory of those conditions has been a straight upward line, really probably starting around 1980 and into the 1990s. And we know, of course, that those are primary drivers of heart disease risks. We've gotten into a situation where, yeah, maybe lipid lowering has had a little effect. We had some good effect from smoking cessation efforts, but then that's all has gotten overtaken by the rising epidemic of metabolic disease.
Right. So I'm imagining all of us who grew up in the 1970s and 80s with the low fat crazes as they were coming to adulthood in the early 2000s, and then the smoking rates going down, then everything it sort of raises or rears its ugly head as a result of all the information that we were, spoon fed as kids in our houses, where we had to have everything low fat and everything was extremely high carb and processed at that point. You mentioned metabolic dysfunction and metabolic disease, and I know this is a big part of your practice. When somebody says metabolically healthy to you, what does this mean overall versus unhealthy?
What it means is that your body is properly using the inputs that you're giving it, primarily the food that we're eating.
Right. Yeah.
Of course, this becomes a combination of what's going on in your body and what you're putting into your body. Both can certainly go awry, and that's causing our bodies to have these negative reactions and become metabolically broken, metabolically unhealthy. And this really multiple avenues of evidence show us that this is probably the primary driver of not only heart disease, but most of the chronic diseases that we're seeing. But the reality is you look at things like cancer, you look at diabetes, you look at things like Alzheimer's disease, these are all related to metabolic dysfunction. And so metabolic dysfunction really seems to be what is driving most of the chronic disease that we're seeing today.
And so you went carnivore, man. Like you decided fully meat-based diet, correct? When did this? I would love to hear about your story a little bit in that capacity. But in addition, let's talk about that particular strategy overall and kind of how you've gotten there from a medical perspective and how you think now this is a therapeutic diet for not just you, but others as well.
Yeah, definitely so. My background is I was a very unhealthy heart surgeon for a long
Shocking.
time. I was morbidly obese. I was pre-diabetic. I knew that I was headed for my own operating table, so to speak. And that was despite the fact that I think I did a pretty good job of following the advice, right? The eat less, move more, count my calories,
Sure.
eat a low fat diet. Like you mentioned, I was raised in a household that we were all skim milk, margarine. We had really almost no sugar in our house. My older brother is a type 1 diabetic, so sugar was off the table for us.
Sure.
And despite that, I became progressively obese throughout my childhood and into my adulthood. I got introduced to the concepts of low carb. It really started for me, ironically enough, at a Society of Thoracic Surgeons meeting. The invited guest lecturer happened to be Gary Taubes. Gary, at that time, had written the book, The Case Against Sugar. Prior to that, he wrote Good Calories, Bad Calories, Why We Get Fat. And Gary is really one of the top investigative journalists looking at the nutritional space.
Sure.
And Gary talked about how it's not necessarily the amount of food that you're eating, it's the types of food that seem to be driving obesity and metabolic disease. And one of the things that struck me was concepts like insulin resistance, that as I think back to my medical school days, I'm not sure I ever even heard the term, or if I did, it was mentioned in maybe a lecture somewhere, and it really didn't get into the data banks. Hearing Gary talk and then reading his books and got me started down the low carb pathway. And, you know, as things evolved, first of all, I lost a large amount of weight, reversed my pre-diabetes, and for the first time in my life, have been able to maintain that. We're now coming up on 8 years later from that, and I've maintained that weight loss. It was then sort of an evolution, lower and lower carb, as I came to recognize it's really the processed food in general. So eliminate processed food, eat whole real food. And then you're left with, okay, I can eat some meat, I can eat some vegetables. And what I really just came to discover was eating only meat, doing a carnivore diet, is really the easiest to maintain for me. It's easier for me to say I'm just not eating any carbohydrates than I'm going to try and moderate my carbohydrate intake. And
Yeah.
I also came to learn, very contrary to what I had been educated, that red meat isn't actually harmful for our health. It isn't harmful for our heart health, and it really is the most nutrient dense food that we can eat. So why not just eat that? And I've tried it. Yeah, I thought it was crazy at first too. And I said, but let me give it a try. And I had positive experiences around it. And I started talking to some other people about it. I kind of discovered the community of carnivores and
Sure.
saw some of the results that are reported in that. And so I have now become very comfortable, first of all, doing it for myself and also telling my patients that it is an option. I don't tell them you need to be carnivore. It's not the only way to avoid heart disease, but it is an option. And many of them have found the same successes that I have using it.
Wow. So this is an intervention that's worked for you, obviously. Are you typically eating like nose to tail? Or are you just eating ribeye steaks every night? Or how do you typically do your carnivore diet? And also, as a secondary question to that, are you using this as a therapeutic intervention with your patients that do have already a pre-existing cardiovascular disease, in the sense of either they've had surgeries or they've had heart attacks? From a calcification, coronary calcification perspective, that might be a different group of people that you absolutely do it in. But do you have a way of thinking about this personally as far as nose to tail, and how do you think about using it in a therapeutic way for your patients with cardiovascular disease that's already well documented?
Yeah, so the nose to tail question, I am somewhat ambivalent to. I occasionally incorporate organs in various ways into my diet, but I don't
Oh, come
really
on, man!
consider it.
More organs.
Uh,
You don't like how kidneys taste and liver taste?
so liver, certainly not. I actually do. This is going to sound somewhat ironic, but I love eating heart.
Okay, that's awesome.
Yeah, that's really my favorite organ to eat.
I love
And
that.
then I'll
Well, that's why
oftentimes
you want to
get
be a cardiac surgeon.
it was, I guess it's destiny. Um, and
That's
then,
great.
I'll get things like a primal ground beef blend that has some liver and
Yeah,
kidney mixed in it.
yeah,
And
sure.
that's kind of how I get my organs. But I know many carnivores who are doing just great and they tell me they never touch organs. So I think it's kind of optional. I view organs almost like a multivitamin. They're certainly very nutrient dense and they're a great way to get all of these vitamins and minerals, but I don't consider them to be essential. And
Okay,
then, for me, there's lots of eggs, which I consider to be, again, a kind of superfood. You got everything in there that you need to make a chicken. So you're getting it all. And I mix up my meats. I eat a lot of beef, but I also eat lamb and game meats. I eat a lot of seafood. I'm fortunate to live in Florida, so I got easy access to good fresh seafood. I think that's all important. Dairy is an occasional thing for me that, again, some carnivores absolutely can't do dairy, some do. I think these are all things that you can play around with within the carnivore framework.
yeah,
The way that I
yeah,
look at it with my patients is this: the data shows us very clearly that insulin resistance is the biggest risk factor when it comes to cardiovascular disease. It
sure.
dwarfs in magnitude anything we can look at on the cholesterol front. And we can dig into why that might be. But accepting that insulin resistance is a major driver of cardiovascular disease. And for people with insulin resistance, which is almost everyone with cardiovascular disease, the best way to reverse insulin resistance is with carbohydrate restriction. I guess you could say extreme, but I don't really view it as extreme. At the low end of the carbohydrate scale is the carnivore diet. You're essentially getting no carbohydrates with the exception of what might be in dairy and what might be in liver. You're basically getting no carbohydrates. And so that's the way that I look at it. The carnivore diet is just a very low carbohydrate diet. And so I am perfectly comfortable recommending that to my patients because our objective is to reverse their insulin resistance. And I know low carb diets in general and carnivore diets in particular to be an excellent way to reverse insulin resistance.
Yeah, and I think that's a big one, right? The insulin resistance and everything that goes from there. Pardon the interruption. This episode is brought to you by Transcriptions, makers of precision dose, physician formulated and pharmaceutical grade formulas in the form of a buccal troche. For this episode, check out TrueImmune. This is our newest formula for immune system optimization, for anti-inflammatory capacity, for an anti-infective. It's taken at night because it also increases deep sleep. The only ingredient in this is cordycepin, the potent and most active ingredient in the cordyceps mushroom. Go check out transcriptions.com. Save 10% on your order by using code POD10 at checkout. Now back to the show. As far as I'm aware, and maybe I just wanted to ask you the question, are there any studies specifically looking at the carnivore diet in cardiovascular disease or for insulin resistance specifically, or are you kind of extrapolating the data from low carb diets in general as having a significant impact on insulin resistance? For example, the ketogenic diet, as we know, has an impact on it.
Yeah, so it's a combination. The carnivore diet really hasn't been studied well, and I wish that wasn't the case. We know there are efforts to do that. Now, we can look at some various areas of evidence. So first of all, we can go back to the scientific literature of the late 1800s, early 1900s. And again, carnivore diets in particular were recommended and were studied somewhat. Most famous study around the carnivore diet is an explorer by the name of Vilmer Stephenson. And he did a carnivore diet under medical observation for a year, some of that as an actual inpatient at New York Medical Center or New York University, and then as an outpatient. And they monitor all his parameters and showed improved health outcomes. And then we have observations of populations, again, mostly historically now, that maintained carnivore diets and maintained excellent health. I look at that.
Sure.
Then we have the low carb diets in general. You extrapolate the data that you can from that. What it comes down to, I think, is whether or not you think that meat, red meat in particular, is harmful for health. Because that's really where the criticisms of a carnivore diet come from.
Sure.
And so if you get past that question, and again, I think we have plenty of evidence to get us past that question, the large meta-analysis review, essentially a Cochrane-type review that was done by the Annals of Internal Medicine, published in 2019, looking at the question of meat consumption and cardiovascular disease specifically. And what they concluded was that there was low quality evidence that showed little association between cardiovascular disease and red meat consumption. If we accept that red meat consumption isn't harmful for our health, and it becomes a great way to implement these low carbohydrate diets that we know are beneficial for people with insulin resistance, then why should I have any hesitancy in recommending this? And of course, I always couch that when I'm having the discussion with the patient, I bring up what you bring up. Do we have a randomized controlled trial showing that a carnivore diet is beneficial or safe in heart disease? No, we don't. Uncharted territory.
Gotcha.
But what I know is what we've been trying for the past 40 or 50 years is not working. Low-fat diets clearly are not beneficial for cardiovascular disease. It's time to try something else. And if the patient is willing to take that risk, and again, there are lots of different ways of implementing this, and you don't have to go full carnivore. And we talk about all the different options. For me, the high level kind of principle, the guiding principle is eat real food first and foremost. And if you want to do some veg, you want to do some meat, you want to do either of the extremes. I do have patients that are on whole food, plant-based diets, and I have people who are on carnivore diet. And ultimately, I think the elimination of processed food is probably the most important thing that we can educate people on and guide our patients on.
Yeah, 100%. I mean, I always tell people that if you go vegan or you go carnivore, in the beginning, everybody's going to feel great, usually, because they're getting rid of all the processed junk that was in their diet, especially if they're hydrating themselves and doing other things that are good for them. I always like to go back to the research. It was a funny research headline about a research paper that I just saw, a new one that meat causes diabetes. I'm sure you've seen these kinds of things always. Yeah. I mean, the challenge with these is that they're not just testing meat in these patients, right?
Yeah, when you ask, especially the average American, did you eat meat? And they say yes, that's usually going to mean they got a burger with the bun, with the toppings, with the fries. They drank a soda with it. And so
Exactly.
that becomes the challenge because, again, eating a carnivore diet is certainly different than eating meat in the context of a standard Western diet. And that's, again, what we need to acknowledge. And I know it's a struggle. Talking to my colleagues, getting them to think about it
Right.
in that way is very challenging. And I fully acknowledge and fully recognize that a cardiac surgeon eating a carnivore diet, it's like a shock to the system. Like,
Yeah.
how could this be? And yet, again, I continue to see it in my own health. I continue to see it in my patients' health and in the larger community. People are getting very real improvements in their health with this strategy. I
Yeah.
would love for there to be the formal research, and I hope one day we have it.
Right. It's so hard to piece out all those other things. That's what I always laugh at those headlines. Like new study shows that meat causes diabetes. I mean, oftentimes there's just clickbait headlines, and there's a
Yeah,
lot of political stuff going on with the ethical treatment of animals and climate change and all that kind of stuff.
yeah.
Do you have a preference? I mean, in the world that I live in, it's always grass fed, it's pasture raised, it's blessed every day and given hugs on the farm kind of meat. Would you even recommend this to somebody with cardiovascular disease that didn't have options for those kinds of types of meat and only could get factory raised farm kinds of things?
Yeah, so I agree. That's what ideal looks like. Your regeneratively raised, 100% grass fed beef from a nutritional standpoint is going to be better from all these other concerns, maybe around environment and animal welfare and all of that. Some people would consider it to be low quality meat, inexpensive meat, the factory farm stuff is still going to be better than the processed food. So if
Right.
that's your choice, I know people who have implemented carnivore diets using the least expensive meat they can find. They go get the $2.99 a pound factory farmed ground beef and they eat that all day, every day. And you know what? They do great. They have great results from it because it's better than the processed food. And ultimately, I tell people get the meat that's affordable to you, that's available to you. If we have the studies showing that carnivore is safe, then maybe we'll get to the studies comparing people that do organic, regenerative, whatever, versus factory farmed and see if
Yeah.
there's much of a difference. When you really do look at that nutritional difference between, let's just say, 100% grass fed beef versus grain finished beef, what you see is it's really not a huge difference.
It's higher in
One of
omega 6, right? I mean, I did
Yeah,
a,
it's mostly
yeah,
omega 6. Some
yeah,
of the other nutrients as well.
yeah,
You look at some of the fat soluble vitamins and the quality of the fats that are in the meat. There's some, variation there, but omega 6 is probably the main concern.
right.
And ruminant animals can convert when they're fed polyunsaturated fats, they can convert it back to saturated fat. That's one of the magic of ruminant animals. Non-ruminant animals like humans, like chickens, like pigs, can't do that. So when we get around to the discussion, one of the nuances there is the difference in beef quality may not be all that big. But if you're looking at your poultry or you're looking at your pork, it
Hmm.
may be more important to think about the sourcing there.
Interesting. Okay.
Personally, I really don't eat a lot of chicken. I just don't find it all that interesting. And I'm probably more careful about my pork consumption and sourcing that well and really only eating that at home when I know where I got it from versus if I'm out at the restaurant, I don't think that much about is the burger that I'm eating grass fed or not. I know
Gotcha.
it's almost certainly not, and it's still a good option in my
Yeah.
mind.
Yeah, I did a research paper in medical school, or was it residency? I think it was on factory farming and overall subsidies that were given to grain producers as opposed to fruit and vegetables and the farm bills and things like that. And I remember going into detail. This is like back in 2009 or seven or something like that, and looking at the omega 6 versus omega 6 content versus factory farm meat versus pasture raised meat, for example,
Yeah.
and some nutrient density things. But this kind of brings on one of the other topics that I know you like to talk about, and I haven't really spoken about on the podcast before, a little bit on the seed oil side of things, because that's where
Yeah.
we get most of our omega 6s. So you talk a little bit about the evolution of seed oils and why they cause inflammation overall?
Seed oils, vegetable oils, processed oils is how I'll usually call them. They were really first introduced in our food supply in the early 1900s and became very common around World War II,
Right.
1940s, 1950s. And again, how did these things get in our food supply is a pretty interesting story. These were industrial oils, industrial lubricants, and for various reasons, someone, as a way to make them more widely used, to use the byproducts of the industrial processes, someone figured out that you can detoxify them enough that they don't immediately kill you. That's essentially what was done. And so they got introduced into the food supply. The food industry loves them because they are cheap to produce and shelf stable, and they increase profit margin. And they were very smart with the marketing, even calling them vegetable oil to give that connotation that this was something healthy for you, even though they're far removed from vegetables. A lot of them have nothing to do with vegetables. When the heart disease epidemic really came to a head, again in the 1950s, and for reasons that aren't all scientific, it was decided that saturated fat was what was driving this
Right. Right. Ansel
epidemic of
Keys.
heart disease,
Yeah.
Ansel Keys, exactly. So the answer was, well, we have these oils that are unsaturated. They're polyunsaturated. They're the exact opposite of the saturated fat. So they must be good, right? And everyone's like, yeah, that makes a whole lot of sense. Great. Here's the problem. They did the scientific studies, right? One of the best done studies on polyunsaturated fats as a substitute for saturated fats in the diet was called the Minnesota coronary experiment. And these were inmates in mental institutions, so they can control everything they were eating. And in a blinded manner, randomized manner, they put one part of the population on the usual diet with butter, and they put the other part on these polyunsaturated fats, substituting for the saturated fat. So they had a butter substitute
Yep.
and they had other substitutes. And, they ran the study. And at the end of the study, not only did they not find any reduction in cardiovascular disease in the patients consuming the polyunsaturated fats, but they actually saw an increase in all-cause mortality. And so what happened was the study results never got published. They got buried.
Yeah.
And it was only years later that this was discovered. And oh, by the way, there were 2 or 3 other trials done in a similar manner, and they all showed the same results. None of them showed an improvement in cardiovascular outcomes. But despite that, because of the mechanistic idea, it became well accepted that polyunsaturated fatty acids, these vegetable and seed oils, are beneficial for our heart health. And they got the stamp of approval from the American Heart Association with a lot of money behind it.
And still do.
And still do. And that's really where we're at. And now it's, again, been widely determined, I guess I should say, that saturated fat is not a driver of heart disease. This has been acknowledged. This has been shown in the meta-analyses of the randomized controlled trials that saturated fat is not associated with cardiovascular outcomes. And it's sort of been quietly removed from the dietary guidelines, limitations on saturated fat. Yet it's still the widely held belief. This is the type of things that makes it difficult to start talking about doing a carnivore diet, for instance.
Yeah. I mean, it's such an interesting history and so fraught with politics and ego. And what is the book? It's by Nina Teicholz, so like the big fat lie, I think.
Yep.
Is that the one? Yeah, that's a great book. I remember reading that.
Yep.
Big Fat Surprise. Thank you.
Yeah.
That was a great book that I read many years ago, which was really transformative from my understanding of all this work as well. I grew up the son of a chiropractor and who was always crazy and doing crazy kinds of diets in the 1980s. So I didn't have this like low fat craze like everybody else did, but just learning about all of this and how it's sort of colored everything that we do. And now you have a clinical practice where you're seeing patients and trying to keep them off, your operating table, although you are still operating. I know that's not going away anytime soon for the reasons we've mentioned. When you're thinking about screening in these cases, like in the sense of now that you have people coming in, what are your best ways of screening your patients now you feel like and for early, either for early coronary disease or for surveillance? What are you doing with these patients now to try to prevent things and reverse things as much as you can?
Yeah, so I think we have really two areas there to look at. One is blood work, lab work, and the other is imaging. On the blood work side of things, it's obvious to me, it's obvious to many others, but it is not well accepted that the primary driver of heart disease is insulin resistance. And
Right.
again, this is not new. We can go back to the work of Gerald Reaven in the 1970s and 1980s, and he very clearly showed that, for instance, when you look at people who come in to the hospital with a heart attack, a cardiac event, over 90% of them show insulin resistance if you test for it in the right way. And we can contrast that to cholesterol. And the reality is, when you look at patients that come into the hospital with a heart attack, let's say heart disease, only about half of them actually have an elevated cholesterol level. It shows you the magnitude of risk. The Women's Heart Initiative study, which published in 2021, showing that the risk associated with insulin resistance when it came to cardiovascular disease was about 6 times the magnitude of the risk associated with elevated LDL cholesterol levels. So that's not saying that cholesterol is meaningless. That's not saying ignore cholesterol, but we got to look at insulin resistance. We got to manage insulin resistance. So that's at the top of my list when we're looking at blood work.
Sure.
Along those lines, you look at things like inflammation markers. I'm a big fan of looking at lipid quality, not lipid quantity. So specifically, you're looking at your NMR, your advanced lipid panel, you're looking at particle sizes. But if you have a lot of healthy, good quality cholesterol, I'm not sure that's a problem.
Right.
So that's what we're looking at on the blood work side.
What about ApoB? Do you do ApoB testing too? That's a big
Um,
one these days that people are talking about.
Yeah, so I look at ApoB, but again, the context of ApoB is the lipoprotein that is on both large LDL particles and small LDL particles, and it's also on VLDL and IDL particles. So if someone comes to me with elevated ApoB, and that elevated ApoB is mostly large LDL particles, I look at that as a very different situation than the person that has elevated ApoB and mostly small particles and a lot of VLDL particles. Now, on a population level, the reality is that the vast majority of people with elevated ApoB are going to be in that latter situation and have
Right.
small dense LDL and
Right.
VLDL because they're insulin resistant. But again, when we find those people who, yes, their ApoB is elevated, but it's because they have only, or a predominance, we never have only, but a predominance of large LDL that we know is not involved in atherosclerosis, that may not be a problematic situation.
Got it. So are there certain populations that you found that to be the case in the sense that they have an elevated ApoB, but they also have larger LDL particles? Is it people that are like lean mass hyper-responder kinds of people typically, or is it in a particular population you've seen that to be primarily the case versus, like you said, the greater population likely will have the smaller LDL particles that are more atherogenic?
Yeah, so it would really be people that are insulin sensitive in general. So lean
Okay.
mass hyperresponders are a subtype of that, but the primary determinant of your lipid particle sizes is going to be your insulin resistance or insulin sensitivity.
I see.
So it really becomes a marker of that. That's again why I focus on the insulin sensitivity part of this
Sure.
so much more, because I know
Gotcha.
that if we improve that, we're now improving the quality of the cholesterol particles downstream.
Pardon the interruption. This episode is brought to you by Health Optimization Medicine and Practice Association, a nonprofit organization training practitioners how to optimize health rather than treat disease. For this particular episode with Dr. Philip, check out the metabolomics module. This is our foundational module, optimizing vitamins, minerals, nutrients, cofactors, checking out diet and lifestyle and how this all integrates into creating a comprehensive plan for our patients and clients. If you're a practitioner, this is the course that you need to take to optimize the health of your patients and clients. Go to homehope.org, Use code podcast10 at checkout to save 10% on your order for this module or any module of the Essential certification. Now back to the show. Gotcha. I know some of the cardiologists I've spoken to are also doing things about LDL production and also clearance, in the sense of certain types of, some people are just making a lot more of it and not clearing it. Some people have a lot more sites that can bind LDL. Are you ever looking into that stuff as well, or is that sort of less important in general?
I don't find that to be as informative, to be honest, because again, it's still kind of looking at the quantity question. So that's digging into, okay, someone has a lot of LDL, ApoB, whatever marker you're looking at. Why do they have a lot of this? And then you can look at production and receptor activity and recycling. But again, you're still not getting the quality issue, which is what I really think is most important here.
I see. Yeah. Okay, cool. So let's go over to some of the other types of screening that you'll do.
Yeah. So then we have to look at imaging, because ultimately, if we're concerned about plaque in the arteries of the heart, why not? Let's look at, do you have plaque in the arteries of the heart? And it's so interesting how we dance around this and we look at, these risk markers and all of these other things. And we have a very good test for looking at plaque in the arteries of the heart. And that's the coronary artery calcium scan. And, this is a great screening test. And again, it's only the screening test. It's not the definitive test, but it can tell you whether or not you have evidence of plaque in the arteries of your heart. And I'm a big fan of coronary artery calcium scans. I advocate for them widely. They're inexpensive. They're easy to do. The radiation exposure is low enough that we can do this on a repeated basis, depending on the situation.
How often can you typically do them?
Yeah, so there are some patients that we get them yearly, because we're using that as a marker of, is your heart disease worsening or not?
So it's like the same way we're doing it for a lung cancer screening in patients that are high risk, like a low res CT for those guys, the same kind of deal, like low res.
Exactly. Yeah. The radiation exposure is on the same level. So again, comfortable doing that. And it's our marker. So we know that if you have a certain amount of calcified plaque today, what happens over time?
Right.
If that amount of calcified plaque is increasing steadily, you're at risk of having a clinical event, having a heart attack. If it's not progressing, we also know that you're at low risk of a clinical event.
It makes sense.
That's, and again, not everyone needs to get it every year, but depending on the situation you're looking at. So I think everyone should have it at least once. I think a reasonable age to start at is probably 40 if you're a male, and probably 50 if you're a female.
Sounds like I'm due. Okay, gotcha.
Yeah, maybe you want to do it even a little earlier if there's reason to be concerned, family risk. And if you know you're insulin resistant, for instance, maybe you start earlier. And then you see, and I acknowledge, if you have zero plaque and you're a 40-year-old male, that in no way means that you're protected for life. It's something you want to keep an eye on. Maybe every 3 to 5 years, you're now repeating that to make sure it stays zero. What I do know is, if you're young, let's say you're under 40 and you get one of these scans and your score isn't zero, I don't care if it's single digits, that is a major red flag, because that means you've already started this process of plaque formation. And we got to get on top of that, because that's how, again, these 30 and 40-year-olds are ending up on my operating table, because they started accumulating plaque probably in their teens and their 20s. I honestly don't really think it's ever too early to do these. I mean, within reason, I'm not screening infants, but if you're a insulin resistant type 2 diabetic 20-year-old, go get a CAC scan, see if this process has started or not.
Yeah. And then there is an opportunity also not just to look at hard plaques, but also soft plaques using different mechanisms in screening as well, correct?
Right. So then we have the CT angiogram. We're going to get more detailed information, because we're not going to see just the calcified plaque that we see on the CAC scan. We're now going to see the non-calcified soft plaque. We can actually quantify degree of stenosis in these blood vessels. We can even, with the most advanced CT angiography today, do what's called FFR testing, fractional flow reserve, where we can actually determine if there is a significant reduction in the blood flow through an area of stenosis. We can get pretty advanced now with the CT angiograms. And I think it's a great test in the right situation. I don't think it's the ideal screening test because of those other considerations.
Right.
But again, in certain situations, I use it. And sometimes people do get it as the screening test. And the limiting factor there becomes, okay, we don't want to be repeating this test year after year after year. And so it can become a hybrid approach because you can get a CAC score at the same time you get your CT angiogram. And we can kind of correlate the two and then say, okay, now we're going to follow the CAC score more frequently. And we're only going to use the CT angiography on an intermittent basis.
Yeah. Have you ever had anybody come out with a clean CT angio for soft plaque? Because I was talking to a friend of mine who's a cardiologist, Michael Tywin, who's actually on the podcast a little while ago. And he was telling me that he does this Clearly technology, which I guess is a butlet on top of the CT angio. And he said he's never had a patient that's been fully clean with soft plaque, at least, no matter who he's checked before.
I do see people who have 0 scores on CT angiography, but you're right. It's not as detailed as the Clearly test. The Clearly test is kind of the highest fidelity test we have today. And honestly, it's not as widely available. So I don't have a whole lot to draw upon there.
Understood.
We go back to historical studies around cardiovascular disease. And there was I forget the name of the study, but basically they looked at infants and young children that were killed in car accidents and looking at their blood vessels, they see fatty streaks, right? And the concept is that the fatty streak is a precursor to the plaque. That is not 100% worked out, but if we accept that, from early on, and again, I also look at our environment as toxic from birth. There are vegetable and seed
100%.
oils in infant formula. There's sugar everywhere in infant formula. Even infants that are being breastfed are getting some of these things if the mom is eating it. I would say it's realistic that, it's almost impossible to have no plaque. But again, very low levels of plaque we know don't have any real clinical relevance to them in terms of risk of heart attack.
Yeah, I remember hearing a study talking about World War II soldiers that died and they had autopsies, the same deal. They would see fatty streaks. They would see early signs of atherosclerosis as well. This is the 1940s and 50s. So I agree with you. I think we're all creating these things at all times. The question is just how it progresses. A lot of it related to insulin resistance, as you said. So I ask this question to everybody. What are the 3 ways that you can live smarter, not harder? And this can be anything related to your work as a cardiovascular surgeon, in your integrative practice, et cetera, or anything that has nothing to do with that at all.
The first one, we mentioned it earlier, is going to be eat real food. That's going to make you smarter, and it's going to make you not have to work as hard to be successful in life and remain healthy. Number 2 for me is finding enjoyment in life. There was a study that just came out today as we're recording this that showed the markers of endothelial dysfunction in people that were angry. They got some healthy people in a lab, and they showed them whatever pictures or whatever to make them angry. And they measured their endothelial markers and showed endothelial dysfunction with anger. So you got to stay happy. You got to enjoy
Sorry,
life.
New Yorkers. Yeah. You
And,
grew up on the East Coast. You got to be careful over there, guys. Come on. All right.
Yeah, exactly. It's a hard one. Ironically, I posted this onto Twitter with the understanding that probably just getting on Twitter these days makes you angry. It's a conundrum, but
high correlation. Yes.
Yeah, exactly. I think for the last one for me is really remain curious. I'm sure you heard it in medical school. Half of what we're teaching you is going to be proven to be wrong throughout your career. And it's up to you to figure out which half. And honestly, in the first part of my career, I don't think I really thought about that much, but I think about it a lot today. So remaining curious, being curious, I think is another key to working smarter and not harder.
100%. Yeah, I love that. So Philip, tell the audience where they can find more about you, what you're doing, your books, et cetera, so they can follow you. I know you have your own podcast as well. So
Stay Off My Operating Table. It's the name of the book, widely available in all the usual places. And it's also the name of the podcast, which you can find in all the usual places as well. And then for me, I Fix Hearts is where to find me. That's my tag on all social media. And you can go to ifixhearts.com and you can find out all the ways that me and my team work with patients to keep them off the operating table.
Love it. Well, thanks for all the work you're doing, Philip, both in the hospital and very much outside of it. And I look forward to speaking to you again soon. Okay, have a great day. Thank you so much for tuning into another episode of the Smarter Not Harder podcast, where we answer 1 cent solutions to $64,000 questions. And this is a fantastic episode talking about various aspects of cardiology, cardiac care, cardiac surgery, statins, lipids, screening, the carnivore diet, and so much more. If you like this podcast, don't forget to like and subscribe below. Please share with your friends. Spread the love of the Smarter Not Harder podcast. We hope to see you next time.